essential monitoring and equipments. Without this one, we cannot able to do anything. The responsibility of the staff nurses again coming. Ensure all specialized equipment is ready. We have shown everything that equipment is ready, then only the nurse can take the patient in a case. Set up trolley and equipment, check for the perfusion fluid, eyes to get ready for the ball pains and backbench liver, perfusion packing, perfusion clothes and instrument count. Then everywhere we are using this patient surgical safety checklist according to the WHO. This safety checklist we are using. So intraoperative management. Why the intraoperative management is important? So monitoring again the long surgery will take the long time. Surgery 10 to 30 hours will take. And there is a continuous monitoring. If suppose any parameters is going down, how to maintain the fluid imbalance, hemodynamic stability is first important. So that loss management they have to do. It is there, they have to do that one. Now, one small video is there, you can see that one, and this 30 hours strategy we can see within a few seconds. Watch properly. Only working nurses are getting chance to see the surgery. That is the reason we reached that way. Now you can see the receiving is how they are going to attach. See the regeneration. So why I put in this video means because whoever is working in the post-op area, they doesn't know about what is happening inside. And suppose patient is getting severe bleed of that, but they will not bother also. That brain is going in, there is nothing to worry. No, we cannot able to worry. We cannot able to live like that. We have to be worried because something maybe some stitches removing from that arteries and veins, vessels and everything they are keeping it together. Is that it is a serious concern. We have to act immediately. Otherwise, surgery is success, but patient is not. The situation is not like that. So we have to avoid all these things. And about it. I will finish immediately, don't worry. Understanding the organ preservation technique, how we have to preserve these organs. So organ preservation, minimal requirements and maximum safety. What is ischemic time is we have to manage the whole ischemic time and suppose to get it preservation solution we cannot able to use and its protocol we have to follow, otherwise there is no ischemic damage. And usually HDK solution we are using for that one to preserve this infant. And phase of organ damage, the timing for the warm ischemic phase and cold ischemic phase we have to maintain at the proper manner, otherwise the graft or these things will failure and there is no use for that one. Triple bag technique is followed for the cadaver. That's triple bag means you have to see that solution. The first bag is coming under the solution, you can see that one. And then second bag, again the second bag you can see how they have put it there, that one. And the third bag is coming. The first bag is placed in the second bag face down and second bag is placed in the third bag face down because lot of the ices are there in that one. And the post-operative management, this is the ICU, it's in the data post-op. So monitoring again, the hemodynamic monitoring we have to do the patients for bleeding, vitals, and urine output, everything is required, and we have to maintain the pain management. Usually we are using the PCA pump. So respiratory and the cardiovascular care, as per the principle of 2025, early extubation is encouraging for the patients. So first day within in the OR itself you can extubate the patients. Otherwise within 2 to 6 hours you can plan for that one. And an exogastric route is not that much importance nowadays. Start 6 of water within 4 to 6 hours. And pain management, yes, definitely we have to be early mobilization is preferring. Day 1 we can remove the urinary catheter and we can allow the patients to take orally. Mobilization has to be, and the patient is taking oral well, then IV fluid we can stop. Then analgesic also we can switch off to oral. So second day and third, remove the artery lines, remaining the drains. If output is low, continue aggressive mobilization and the hospital protocol you can start. And fourth to say the target of discharge from ICU ward. And the 6 to 9 discharge criteria, we can see the patient is tolerating everything, we can give the normal diet and everything. So we can plan for that one. And infection control practice, it is necessary. Then early mobilization we have discussed, and nutrition, the food nutrition we have to give, monitoring and diagnostic blood test we have to do image, X-ray, tool of the electrolytes and nourish your body and cherish your liver. So nutrition is most important. And we start criteria of the donors. So all laboratory investigations has to be normal. Then lot of the myths and facts is there in that one. I'm not going to explain. I can take 5 minutes more. Okay. So this is most important nowadays. The education is most important for the society. People is having a lot of confusion. So donating part of your liver is extremely dangerous or life-threatening. That is the myth, but no. This is very rarely found in between 500 to 1000, maybe one case scan was the problem. Otherwise, nothing is there. And liver wants to grow back fully and you will have a health problems forever. No, it is not there. We have so that the regeneration program, it will be 2 weeks, they will become the normal culture. You need a lifelong medications or restriction of nothing is there. Then women cannot have children after donating. That is also one thing. People are still they are having doubts regarding nothing is there. They will be in the normal life. They can become the pregnant and they can deliver the baby also. Then surgery makes you weak or unable to work, exercise, travel normally. All these things are nothing is there. Within 6 to 8 weeks. they can be on their own normal activities. Only blood relatives or building blood exact sample blood type can donate. Now we have already done that one also. The role of the nurses, monitoring, assessment, pain management, pain management, and patient and family education, follow-up coordinations. Now, discharge education, that is the main role of the nurses by the patient post-discharge education. Because patients are going to home, they have a lot of doubts. I can do my exercise, I can eat normally, I can sit. A lot of the doubts are there, then that is our responsibility. We have to explain the patients about their normal activities, how to take their, how to take their diet and nutrition of the patients, medication and follow-up, when to be a normal situation. Patient can be normal within 6 to 12 weeks. They have to be and when they have to approach the hospital, seek immediately medical help support. Suppose the patient is having some fever, more than 100 degree Fahrenheit or more than 38 degrees Celsius, they immediately they have to approach. Some leakage is happening from the wound, they have to come some redness suddenly, they have to come to the hospital to justify what prescription is taking. So this is our application that so that donor is having 2 times they got cardiac attacks. Then also they have given the liver to the result, and now they are really happy. Thank you so much.
For such an engaging session. Your presence have truly enriched the session tremendously. I would request Rosama to please facilitate, ma'am.
Guys, please give a big round of applause. Moving forward, we are privileged to have with us today Ms. Hiteshi Khatri, a nursing clinical instructor from Max Sake. We are eagerly await to valuable insights. So the topic for us, stabilizing the critical ill patients and the nursing priorities in acute liver failure. Over to you.
Hi, good morning all. I'm sorry my session was earlier, abhi late ho gayi thi main to. We'll start now. So we'll be talking about stabilizing the critically ill patients. Especially we'll be focusing on nursing priorities in critically ill patients, right? So what is liver failure? Liver failure occurs when the liver loses its ability to perform essential functions such as detoxification, protein synthesis, and bile production. So now the topic is what is acute liver failure? Acute is a sudden onset of failure, right? So acute liver failure is a life-threatening condition characterized by rapid deterioration of liver functions in individuals without having a pre-existing disease. So nurses play a vital role in the early recognition, ongoing monitoring of the patient, and supporting management of these patients. So what are the causes? There are a lot many causes of having this acute liver failure. So out of which common causes are, one is acetaminophen overdose may occur. Next, viral hepatitis, especially hepatitis A, B, or C. There are chances of having drug-induced liver injury, alcoholic hepatitis. Patients are there who has a genetic disorder, that is Wilson's disease, liver ischemia. These are the common causes for liver failure. Next, we'll be discussing in further slides for neuro or encephalopathy. We'll be discussing about airway and circulation, coagulation, metabolic and electrolyte imbalance, infection prevention, renal monitoring, how to support family in this acute liver failure, also medication safety for these patients. So how do we assess these patients for neurologically? What do we do for neurological assessment? Basic. We go for GCS check, Glasgow coma, For intubated patients, we have a machine there, BIS monitoring, right? Has everybody seen this? BIS monitoring we do for intubated patients. And doctors also perform a ONSD test, right? Optic nerve diameter test. And for these patients, I think we should always check continuous glucose monitoring. CGM monitoring should be done for these patients. We have to check ammonia levels for these patients to find out their encephalopathy status. Next is how to maintain these patients' airway, breathing and circulation. So why this patient needs intubation? If they are having confusion, they are disoriented, their GCS is low, the doctors intubate this patient. So now, what are the nursing actions in this? What are our priorities? So we have a priority maintaining their airway, especially if their encephalopathy is worsening. Prepare for intubation and decrease risk for aspiration. Administer oxygen, monitor saturation while doing all this procedure. Continuous monitoring for blood pressure, like hemodynamically stability has to be there. Use vasopressors if in case patient is hypotensive. IV access for fluids, medications and blood products may be needed in this condition. Next is, these patients are very coagulopathic, right? All the liver patients are very coagulopathic, so they are at risk of bleeding. So what do we done? What to be done to prevent these patients from bleeding? So first, we have to check their INRs, their APT levels, just to make a site कि these patients are having this much of INR. So less invasive procedures to be done for these patients, right? If bleeding is there, we perform a TEC, thromboelastography is performed so that we can further proceed for transfusions for these patients, right? Next is, we watch for bleeding signs, that is bruising may be there, hematuria may be there, or some GI bleed, RT bleed may be there for these patients. Then we minimize invasive procedure, and yes, for these patients we administer vitamin K for over 3 days, OD. So this has to be done for all the acute liver failure patients. So sorry. Next is how to manage these patients' metabolic and electrolyte imbalances. So liver failure leads to severe metabolic derangements. Nursing actions for this is, number one, we have to continuously check their glucose, and their target blood sugar should be 120 to 150 mg per liter. We have to continuously monitor their electrolytes, especially sodium, potassium needs to be monitored, magnesium and phosphorus level. We have to assess for electrolyte imbalance if there is, and we have to administer dextrose or insulin as per the glucose monitoring. These patients tend to have hypoglycemia or hyperglycemia. What? These patients will have hypoglycemia or hyperglycemia. These patients will have hypoglycemia. Very nice. So next is how to prevent these patients from infection. See, as such, these patients when they come, I already said these patients have acute, like sudden onset of liver failure. So they were not infected, they were at home, they got sick. So nurses play a vital role in preventing these patients' infection. So we have to follow all the bundles, right? So nursing actions are, use strict aseptic technique for all invasive lines. We have to monitor for subtle signs of infections like fever. अगर है वैसे तो इन patients में these patients will not have fever. These patients have hypotension otherwise, right? Obtain cultures. We can send markers, viral markers for these patients. We can administer empiric antibiotics to prevent further infection, right? Next is how do we support these patients nutritionally? Now we have prevented their infection. We have prevented their brain neurologically. Now how to prevent these patient nutrition? We have to give them either enteral or parenteral nutrition. So collaborate with the dietitian for enteral nutrition if GI tract is functional. We can start these patients with RTP so that these patients have some mechanism in their body, right? Monitor for ammonia levels. Avoid lactulose. Nowadays we are not giving lactulose. Avoid protein overload. We should not overload these patients to more than 0.8 gram per kg per day. This is the enough good amount of protein. We have to do this, especially in encephalopathic patient, while maintaining adequate caloric intake. And we should not say that we do not need protein. Our body needs some protein. Due to their liver failure, they are not metabolizing much amount of protein. So Only 0.8 gram per kg per day is enough. Next is, I have attached a picture of our recent ALF patient. This is how we intubated this patient. This patient got unconscious, disoriented, so this patient was intubated. So how to manage this patient at the bedside? We should always keep this patient's head end elevated to 30 degrees, minimize stimulation and maintain a quiet environment in these patients too, so that they don't exert pressure. ICP pressure of these patients does not increase. No sponging or harsh movement shall be done with this patient. Minimum handling should be done. Avoid unnecessary sedatives. No ketamine, no ketamine should be administered to these patients. Prepare for airway protection if mental status declines. Administer fluids carefully and avoid constipation to these patients. Why? Because constipation will further lead to yes, and then also their ICP may get increased, right? So provide enteral feeding for early recovery of these patients. So this is the criteria, Western Haven criteria of attached for hepatic encephalopathy. So we divide grades of HE, right? So number 1 is 0. In 0, patient's level of consciousness remains normal. Personality and intellect of the patient remains normal. Neurological signs, there are no neurological signs. Patient remains like us, conscious, right? And EEG shows no problem. Next goes to grade 2 of HE. Grade 2 of HE, I'm sorry, level of consciousness, day or night sleep reversal. Patient will sleep in the day and will be awake in the night. Then personality and intellect changes will be, patient will forget something. Okay? Confusion starts and agitation starts in grade 1 of HE. Then neurological signs, you can see this. Abnormal only on this. Tremor will be there. Apraxia will be there. Incoordination with holding the glasses, holding the spoons may be there. Impaired handwriting may come, right? We see patients having tremors while writing, while holding a glass. Grade 1. Grade 2 comes, patient will have lethargy. Response to whatever you ask this patient. Personality and intellect changes will be disorientation to time will start with grade 2. Loss of inhibition, inappropriate behavior will start. Patient becomes violent at this time, right? Next, neurological signs, patient will have hysterexis. When you ask this patient to do like this, patient will have starting hysterexis, right? Next is this arthria will be there, ataxia will be there, hypoactive reflexics. In grade 2 of HE will start. In grade 3, where we have to intubate this patient is somnolence or confusion. Personality, in personality, disorientation to play start and aggressive behavior becomes more. Right? Neurological signs remain same. Patient starts having muscular rigidity along with all the signs, and patients will have Babinski's sign in this grade 3 of HE. In grade 4, we don't let this patient go to grade 4. Eventually, we have to intubate. So, in grade 4, patient goes into coma. There will be no sign. Deceleration will start, and in the EEG, it shows slow activity. So, this is the grade. At grade 3, we have to continuously monitor. Nurses has to continuously monitor for grade 3. If this patient is agitated, starts in having tremors, hysterexis, we have to call the doctor and prepare for intubation. Next is fluid and renal monitoring. In fluid overload and renal failure are common in acute liver failure patients. We have to continuously monitor intake and output charts of these patients hourly. Monitor creatinine, blood urea nitrogen, and urine output. Also, all we have, along with liver function, we can have renal dysfunction as well. We can use if this patient is sick, we can use renal replacement therapy. Restrict fluids if hyponatremia is there. No normal saline should be given if hyponatremia is a vital role. Now this family factor is a vital role. Now this family factor, patient was alright, a young adult will be there, and patient is suddenly on ventilator. So we have to support this family. We have to tell them that this patient is sudden onset.